Hello and welcome back, everybody. What we're going to be discussing in this lecture is going to be a bunch of different types of blocks, heart blocks. Whenever I say block, I mean an interruption in the normal electrical impulse that reaches down through the heart. So we can have blocks that occur a lot of places in the heart. We're going to talk about those in detail today. We're going to talk about if you remember, we kind of left off. The last thing we talked about was rhythms that originate in the AV junction and beats that originate there. And so we're going to move on down. We're going to start talking about rhythms that originate even lower than that. And then we'll talk about the blocks that occur down there as well. So they're all kind of intertwined. So we're going to start out by talking about bundle branch blocks. So if we remember, as our impulse leaves the AV node, it travels down the bundle of His, and then it splits. It splits in two directions, to the left bundle branch and the right bundle branch. Our left bundle branch goes and innervates and provides the electrical stimulus for contraction in the left ventricle, and the right bundle branch stimulates contraction in the right ventricle. So we'll talk about, we kind of understand the normal flow of things. And so what we're going to be talking about today is whenever we have interruptions in that flow and what it looks like on the EKG. Okay. All right. Sorry, guys. Things are going a little crazy at work right now. I'm trying to do 4 things at once here. But you now have my attention. So, right now we're going to be talking about bundle branch blocks. These are pretty common. You'll see these a lot of times, in a lot of different patients. And we want to learn to be able to pick that out on an EKG. And the importance of that we'll talk about later on, and why it's important to recognize bundle branch blocks. But we're just going to discuss them right now, and then this will come into play later. So a bundle branch block results from an interruption of the normal impulse that goes down the branches. So we can have a complete bundle branch block, which is going to be characterized by a pattern of cross polarization over the septum. What this means is when we do have a bundle branch block, what's going to happen is you'll have one ventricle that depolarizes before the other and creates a wide QRS with, and you could see characteristic bunny ear sign. Obviously, we'll look at examples of that shortly. So what happens whenever you do have a bundle branch block? So just one of your bundles is completely blocked off. They can be partially blocked off as well. But for this explanation, just consider one of your bundles that supplies a whole ventricle with electricity completely blocked. So what happens is you still do get depolarization of that other ventricle, but down the if you have a right bundle branch block, the left bundle is still depolarizing normally, and since the right bundle is not receiving that impulse, it actually receives the impulse from the left side at a slower cell-to-cell rate. So it's depolarizing a lot slower, which gives us a wide, bizarre QRS complex. Understand that that's what the process is. Instead of just looking for a wide QRS, understand that that's why we do get that wide QRS. So this is what I was talking about with the cross septum conduction. Whenever we have that block in the right bundle, your left bundle branch is what is supplying the electrical impulse for the right ventricle to contract. It just occurs slower because it has to pass through the septum, cell to cell. And when I say slower, we're talking microseconds. Here's a graphic of our right bundle branch block. So our left bundle branch, you see that first ear mark there on the QRS complex. It's being depolarized normally, so we get our normal QRS, or the beginning of a QRS. Well, since the right is blocked, we have a delay in conduction, and that we have that large QRS there from the slow conduction from cell to cell, conducting through the right ventricle. So if you look at the graphic there with the two, that's the bunny ears, what they're talking about. Not really a reliable method. You don't always see that with a right bundle branch block. We'll discuss some methods for determining. So anytime we have a QRS that's wider than 0.11 seconds, we need to be considering a partial or complete bundle branch block. There's this pretty simple way to determine if you have a left or right bundle branch block. So what you want to do is you're going to look for the wide QRS complex with a normally paced rhythm. So we know that it has to, for these rhythms, we still want to see a P wave with a good PR interval. And then we're going to look for our, bunny ear conduction, which is, you can use to rule in your bundle branch blocks. And then we're going to look in lead V1, which we'll show in the next slide. And we're going to think about a turn signal. If V1 goes mostly up, is deflected mostly up, then you think about flipping your blinker, you push it up to turn right, correct? So if it goes mostly up, then you have a right bundle branch block. If it goes mostly down, and you have a left bundle branch block. So that's one of the easiest methods. There is some more detailed methods that we can discuss maybe in class, but for now, we're going to use that. So first, you want to identify that you have a wide QRS complex. Rule out anything else causing that wide QRS complex, such as a ventricular rhythm. And then determine whether it goes up or down, and that tells you where your bundle branch block is. So here's an example of a right bundle branch block. V1 is just over here. Again, I can't point at it, but look for the V1. It's on the right side of the page there. I just realized that we haven't discussed really 12 leads yet. But for this, we're not interpreting the 12 leads. We're just using this to look at bundle branch blocks. Bundle branch blocks do require a 12 lead to actually determine where the bundle branch block is located. So we look at V1. V1 is mostly deflected down, and it's wider than 0.11 seconds. And so we can say that this is a left bundle branch block. Likewise, we look at V1 again. Oh my God.
Go ahead. Please show us clear of SCA station number 1.
Here we have an example of our right bundle branch block. You look at V1, the QRS is most positively deflected. We have a QRS wider than 0.11 seconds, so this is a right bundle branch block. This is an example of our bunny ears. This is actually lead 2, but this is what we're talking about on an actual rhythm strip, what that would look like. So this is more than likely a right bundle branch block, but without looking at V1, it's pretty hard to say for sure. But remember, the bunny ears method is only good for right bundle branch blocks, but that's what it looks like. That's all we have to discuss on bundle branch blocks for now. So we're going to go ahead and take off. Now that we've reached our, we started up the SA node. We talked about the interatrial pathways and the rhythms that can happen there. We talked about the AV junction and the rhythms that can occur there. We've talked about the blocks that can occur in the bundles. So now we're going to start talking about we're down at the very bottom of the heart. Our rhythms that arise in the ventricles. So we do have quite a few of them that we're going to talk about. I know I may not have warned you guys. You could probably tell before we started. Oh my lord.
Disregarding.
But this is a pretty hefty PowerPoint. It is going to take a while to get through all this information. So just bear with me, and we'll try and get through it. So, as we're talking about ventricular rhythms, know that we're talking about rhythms that arise inferior to the bifurcation of the bundle of His. So you guys remember we talked about after the AV node we have the bundle of His where everything's still together, and then we split off into the right and left bundle branches. So these rhythms that we're discussing here are rhythms that arise. The pacemaker is distal to the bundle of His. So that's what we mean when we say a ventricular rhythm. So these rhythms can occur anywhere from the bundle branches down to the very tip of the ventricles and the Purkinje fibers, and anywhere in between. So in ventricular rhythms, depolarization occurs cell to cell, which you guys should remember that we discussed. It takes longer, it's slower because it's not down the natural pathway of the heart. You're going to have asynchronous mechanical contraction of the ventricles, meaning that as you see your QRS complex, you have to understand that since the natural pathway of electricity is not being flowed, you're not going to have contraction of the ventricles at the same time. So depending on where the ectopic pacer is, if it's located in the left posterior bundle, or left posterior fascicle, that whole left ventricle is going to depolarize before the right ventricle. So you can actually have your left ventricle contracting slightly before your right ventricle does, and that's goes to show why we also in these situations have these wide, bizarre QRS complexes. Now, if you'll remember just a little while ago, we were talking about our bundle branch blocks. This is not the same wide QRS complex that we're talking about. In bundle branch blocks, we're still receiving a stimulus from above. It's coming from the SA node, in the atria, the AV node, somewhere. And the block is what causes the wide QRS complex. Here, the reason our QRS complex is so wide is because that slow cell-to-cell transmission. So different mechanisms, similar end result. Be aware that, and this is why I was saying that you have to rule out any type of any other type of origin for a wide QRS before you can say that you have a bundle branch block. If we have a ventricular rhythm, we need to know that. We can't assume that a ventricular rhythm is actually coming as just from a bundle branch block. So know that with ventricular rhythms, you're also going to have bizarre ST segment and T wave abnormalities because you're repolarizing differently. You're depolarizing differently, so you're also repolarizing differently as well. So here we have an example. You look at the star right there in the septum of the right ventricle, and assume that this is the ectopic focus that's acting as a pacemaker cell. So it's going to slowly depolarize the right ventricle, and it goes out, and so it's slowly contracting or depolarizing as it goes, cell to cell, and so your right ventricle is going to be contracting before. But then you kind of have the color coding that shows, what's being contracted, why it takes so long. So as it takes a long time, you have the initial ectopic stimulus that provides, the red there, and then it slowly goes out to your blue, and then your green, etc. So it takes a while for that stimulus to reach out. So that's why you have your wide QRS complex. So depending on where the ectopic pacemaker site is going to tell us that there is going to determine what our morphology of our QRS complex looks like. So remember that our lead 2, our monitoring lead, is looking up from the left leg to the right arm. And this is our normal, generally our normal path of electricity flow through the heart is from the right arm down. And our camera, as you know, is looking up. So if electricity is moving generally towards the positive electrode in lead 2, we're going to have a positive deflection on our ECG. But with ectopic pacemaker cells, it really depends on where it is to determine what type of QRS deflection you're going to have. There's really nothing set in stone. Just know that you are going to have different looking morphologies of QRS complexes depending on where that pacemaker site is located. If you remember, we started talking and we said, our SA node is our natural pacemaker. And if it fails to fire, then we have our interatrial pathway somewhere in the atria is going to provide our pacemaker responsibility. If that fails to fire, our AV node takes pacemaker responsibility. Or somewhere lower in the His bundle, in the proximal or distal AV node. Well, if those fail to fire, then our ventricular pacemaker is kind of our last bet. Its natural firing rate is 20 to 40 beats a minute. It's that last fail-safe if nothing else fails to fire. So the question, what is your fail-safe if a ventricular pacemaker fails to fire? There is none. Your fail-safe is death, and you're dead. So that's kind of something about whenever we get into looking at some of these rhythms. Remember that this is kind of our last line of defense from cardiac death. So occasionally you can have a P wave in a ventricular rhythm. Not very common though. Whenever you have that ventricular impulse, obviously it's going to retrograde conduct up into the AV node. So there's a couple of different things that can happen. It can either be blocked from leaving the AV node so that it just stops there and depolarizes the ventricles only, or it can be retrograde conducted into the atria and also depolarize the atria. So it really depends. But more than likely, in most pure ventricular rhythms, you don't have any P wave. There can be a retrograde P waves that are buried in the YQRS, or they might look like a notch in the QRS, but it's not common. So the presence of a normal P wave that are not paired with a QRS in ventricular rhythms is going to be an indication of a heart block, a complete heart block. So, and we'll discuss that later. So here we have some examples of our P waves that we could see in a ventricular rhythm. So depending on where the stimulus is, and this is if it makes it out of the AV node and retrograde conducts to the atria, you're going to have, you look at this top example here, that ectopic focus is a little higher up. So our P wave occurs a little sooner in the QRS complex. Whereas down here in the bottom example, our P wave occurs a lot later in the QRS complex, in the ST segment rather, because it has taken much longer for that impulse to reach the atria. It's lower. It's a lower ectopic focus, so it takes a little bit longer for the impulse to reach. Okay. So this is a look at a clinical feature of a particular morphology of QRS complex. Whenever we do have a ventricular beat, Josephson's sign is a good indicator that we are actually dealing with a ventricular beat as opposed to a beat that's coming from a supraventricular pacemaker with a bundle branch block. Josephson's sign can be ruled in, can be used to rule in things such as ventricular tachycardia, and which we'll get into shortly. But what that is, if you see what we call the nadir of the S wave, which is just the first downward portion of the S wave. We have a small notch there, and that small notch is called Josephson sign. It's indicative of a ventricular beat. So as we look at some of our examples of VTAC and stuff like that, look at those and look out for Josephson sign. We'll also talk about Brugada's sign shortly, and a couple other things that'll help us rule in ventricular arrhythmias. So ventricular arrhythmias can occur due to an increased mechanism, or due to increased due to an escape mechanism rather, or increased automaticity. So we have 4 different rhythms that we'll talk about. The first is going to be our ventricular escape rhythms, or also known as idioventricular rhythms. We'll then talk about accelerated IVR, and then we'll talk about VTAC, and then we'll talk about VFib, ventricular fibrillation. Again, except for ventricular fibrillation, if you guys remember when we were talking about junctional escape rhythms, accelerated junctional escape rhythm, and junctional tachycardia, the only thing that distinguishes the three is the rate, and that's the same way with these 3 here. Whenever we're talking about ventricular escape rhythms versus accelerated idioventricular, the only difference is going to be our rate. And then the same with VTAC. We'll talk about premature ventricular contractions. Basically, a premature ventricular contraction is the same thing as our other premature contractions. It's occurring in the ventricles, though. It's going to originate in an ectopic focus. It arrives prematurely. It's going to be wider than 0.12 seconds. Usually bizarre, wide, tall morphology. You'll have an ST segment and T-wave abnormality from it. And you usually associated with compensatory pauses where the P wave is reset. But it's not necessary. Not necessarily all the time. There can be non-compensatory pauses as well. So here's our example of a premature ventricular contraction. It occurs sooner than expected, wider wide and bizarre, pretty easy to pick out. These are not too difficult to distinguish. So PVCs from the same focus, if they're coming from the same irritable cell, they typically have the same interval. So we see our PVC, the first PVC here, and the distance it came from the previous wave. And we look at the second one. That's usually going to be the same. So if you notice that, we're going to realize that that's coming from one individual cell. All right, RNT phenomenon occurs whenever you have a PVC that is occurring on a T wave of the previous beat. RNT phenomenon is a very dangerous. It can be dangerous due to the fact that it can incite sudden cardiac death. RNT is a mechanism in which, whenever it does occur, it can basically create a ventricular reentry rhythm. And causes VTAC, or it can cause VFib as well. All right, unifocal PVCs. Basically what this means, this term you'll hear pretty commonly, you have a PVC that's occurring multiple times, but it's coming from one focus, one focal focus. So we have one irritable heart cell, and all those PVCs are originating. So if you look at the star in our example here, that's where the PVCs are all originating from. We have, 4 PVCs. Obviously, if they're the same, coming from the same focus, they're all going to appear the same morphology of QRS complex on the EKG. On the contrary, we have an example of multifocal PVCs. Here we have multiple different ectopic focus that are firing. So we have different morphologies of PVCs on our rhythm strip. We can also have recurrent PVCs just like we could with PJCs and PACs. So here, our top rhythm, we have unifocal bigeminal PVCs. So every other beat is a PVC. The second one down is unifocal trigeminal PVCs, and then the third one down, it would be unifocal quadrigemini PVCs. An example of a couplet and triplets. Whenever we start seeing these, we need to start being concerned about the patient going into ventricular tachycardia. Yep. So whenever we start seeing multiple PVCs that are being strung together at a time, we need to be a little more concerned. This is a sign that is indicative that the patient could be moving towards being in a total ventricular rhythm, such as ventricular tachycardia. So, recognizing PVCs. As we already stated, this isn't a rhythm, it's a single complex, although they may occur in multiples. They can be regular. They can be bigeminal, trigeminal, as we discussed. Generally not going to see a P wave with them. There's no P to QRS ratio, no PR interval. The QRS is going to be wide and bizarre. There's no grouping or drop beats. Our differential for PVCs, most of the time idiopathic, not necessarily benign, but they can be. Most people probably have a PVC every now and again. Can be caused by anxiety, fatigue, just kind of like everything else. Nicotine, alcohol, caffeine. Common with hypertrophy of the left ventricle, cardiomyopathy, heart disease, and electrolyte derangement. Okay, now, just like we talked about junctional escape complexes, same thing here, except with if the junctional AV junction fails to fire, then we're going to have a ventricular escape complex, hopefully. Whenever there's a supraventricular pacemaker failure, this is what we should have. The morphology is going to be similar for a PVC, but the complex is late rather than premature. So if you look in our example here, we notice that our R-to-R interval there at the first two beats, we have a missed beat there. And so our ventricular escape focus fires, resets the SA node, and all is well. Everything resumes. They can occur in multiples. If we have over 3 escape complexes occur in an order, this is a run of an idioventricular rhythm. We can have P waves that march through the rhythm. We have, in this scenario, we would have some type of complete heart block where the sinus node is still firing, but no stimulus are reaching the ventricles. So the ventricles just take over and they're running themselves. In our example down here, we see our P to P interval never changes. We have our P waves all the way through, but we stop seeing our QRS complexes following those P waves. So we have a ventricular complex or ventricular escape rhythm that takes over until our P wave, our sinus node recaptures the ventricles and continues pacemaking responsibility. So idioventricular rhythms. The intrinsic escape rhythm, this is the intrinsic escape rhythm from a ventricular focus. The rate is typically between 20 and 40 beats a minute. Sometimes anything over 40 is usually going to be considered accelerated for the ventricles. You're going to see the typical wide, bizarre ventricular morphology for the complexes. Here's our example of an idioventricular rhythm. We don't have the boxes behind to measure the rate, but can just assume that it's about 40 beats a minute. So, recognizing an idioventricular rhythm, like we said, rate up to 50 beats a minute. It should be fairly regular. There's not going to be any P wave morphology, although, like we already discussed, you can have the P waves continuing to fire, the SA node firing. They're just not getting through. But we do have a different name for that particular rhythm. So we have there shouldn't be any drop beats grouping. The QRS width is going to be wide and bizarre. No PQRS ratio or PR interval. Accelerated idioventricular rhythm, basically the same thing except a higher rate. The rate's going to be 50 to 100 beats a minute. It's going to be due to increased automaticity. It can be demand-based. Complexes are going to have the same typical ventricular morphology. It should be regular.
Medic 30, 1048, analog at Andover, operate EMS.
It should be regular, except whenever these rhythms start, they typically have a lot of bizarre irregularities to them. So if we have this rhythm, it's accelerated idioventricular, we should never try and suppress this rhythm unless the patient is unstable. So remember that the ventricular pacemaker is the very last safeguard. So if we suppress an accelerated idioventricular rhythm and try and slow it down, we're moving towards asystole, which, if you guys aren't familiar with, is not a good thing. So just kind of keep that in mind. Whenever we have this, there's a reason that we have this accelerated IVR. It's demand, if it's demand based, the
Medic 30, 10-4, we don't have much information. We heard it being given out to Andover, and the only other caller that had any information said they thought the rearview mirror.
Remember that the only this is safeguard. We don't want to be slowing this down, because the reason it is increased, the reason the rate is high, is due to the fact that the body's demand is causing an increased automaticity to sustain hemodynamic stability. Here's our example of an accelerated idioventricular rhythm. All right, so like we said, the only thing difference between this and a ventricular escape rhythm is the rate, 50 to 100 beats a minute. Causes: acute MI, myocardial ischemia. You can have this in reperfusion arrhythmias, cardiomyopathy, digoxin toxicity, or it can be idiopathic. Idioventricular rhythm could be induced due to increased automaticity, or maybe due to an escape mechanism, noting that there's a failure of all supraventricular pacemakers above it. So, ventricular tachycardia.
I just had another caller on the admin line advising of possibly 3 vehicle involved eastbound lane.
Ventricular complexes, same type of deal, except our rate is going to be above
Making sure you said 3 vehicles.
100 beats a minute. Our rates can be
3 vehicles.
be between 100 and 200 beats per minute. It can be higher. Monomorphic VTAC, basically all of the complexes have identical morphologies, whereas polymorphic VTAC, we're going to have varying morphologies from beat to beat. So here's a little word of caution. We'll talk about this. You'll hear this said several times. A wide complex tachycardia is considered to be ventricular tachycardia until proven otherwise.
EMS 1, Andover is triaging 1 yellow, 2 green.
So
30, 10, 4, 1 yellow, 2 green.
we have the reason this is important. We need to
Copy, 50, roll in that direction. EMS 1, if you want to go ahead and start in this way, 1037, until we figure out if they're going to be transports or not, that'd be fine.
All right, guys, I gotta go do work. I guess we'll continue this shortly.
Dispatch from 30, go ahead and show us on scene.
All right, welcome back. Guess that wasn't really a pause for you guys. It's been about 3 hours for me, but we're gonna try and soldier on. So, what we were talking about was, let's see, looks like we were talking about, so whenever we see any type of tachycardic rhythm with a wide QRS complex, we need to have a high index of suspicion of VTAC. This is the most lethal rhythm. VTAC can eventually lead to VFib, which is a non-pulsatile rhythm. So we need to be highly concerned and have a high index of suspicion for VTAC unless we have proof otherwise. So we want to try and rule out VTAC before we just disregard it as being something else. All right, VTAC can be non-sustained. You can have what's called a run of VTAC. Basically, is a period of VTAC that lasts shorter than 30 seconds. Sustained VTAC either lasts longer than 30 seconds or it requires some type of intervention to break the rhythm. Those interventions can vary from pharmacological means to electrical therapy. So the morphology of VTAC is usually pretty bizarre. Remember, these are our ventricular complexes, so they're wide, bizarre. It should be regular, and it's usually triggered by a PVC falling on a T wave. So look at the top picture. You guys remember talking about the QT interval. Basically, the problem what we have here, we have an example of the normal QT interval on top. During this bottom phase, we have an example of a prolonged QT interval, which can be caused by several things, including drugs, normal medications that people are on, electrolyte derangement, myocardial ischemia, etc. So if we have a PVC in that coupling interval that we were talking about, where they normally fall at a certain time past the previous beat, and that QT interval is prolonged, and we have that PVC falling directly on the T wave, it can induce VTAC. So here's an example of what that would look like. We see a PVC falling where that T wave, actually this one's not really shown. It's a premature contraction, but it's not falling on the T wave in this example. And then this incites our ventricular rhythm. Non-sustained VTAC, here again we just have the example here, which converts itself back to a sinus rhythm. This is an example of non-sustained VTAC if it lasts a shorter amount of time than 30 seconds. It is important to remember that we can have two different types of VTAC. We have pulsatile and non-pulsatile VTAC. So if you see a patient that is in VTAC, you need to make sure that they have a pulse, because it is possible to be in pulseless VTAC as well. Here's an example, recognizing VTAC. Same thing as the accelerated ventricular, except the rate's going to be higher. There are some other inclusion criteria that we can consider when trying to identify VTAC. The rate 100 to 250, it should be fairly regular. If it's irregular, very irregular, we need to be thinking about other things. No P waves, no P QRS ratio. QRSs are going to be wider than 0.1 seconds. So here's an example of VTAC right here on a real patient. And that's pretty much it. It's pretty regular. The rate's about 170. and it's wide, bizarre, complex rhythm. So this is pretty easily identifiable as ventricular tachycardia. All right, first and foremost, it's important to remember that VTach is a lethal arrhythmia and needs to be treated. People don't just walk around in VTach. This is extremely lethal rhythm and needs to be addressed. Causes of VTach: acute MI, ischemia, cardiomyopathy, myocarditis, arrhythmogenic right ventricular dysplasia, idiopathic, and drugs and electrolyte derangement. Polymorphic VTach is a little bit different story. It's going to be irregularly irregular. It's anywhere from 150 to 300 beats a minute. The complexes are wide and bizarre, and they lack specific components. You can't really distinguish the QRS complex. The complexes appear grouped with 5 to 20 complexes per group, and the amplitude and polarity is changing. The other name for this is torsades de points. This is French for twisting of the points. If you look at this, it almost looks like a double helix strand. It's very like a DNA strand. Very easy to recognize whenever you see this. Here's just an example of what that looks like. Again, torsades, twisting of the points. And another example. And another example. So recognizing torsades, 150 to 300 beats a minute. It's irregular, no P waves, none of that stuff, but they are grouped in 5 to 20 ventricular complexes, and there should be no drop beats. Okay, so excuse me. Speaking of wide, all right, I'm talking about wide complex tachycardias. It can be difficult to differentiate a wide complex tachycardia from VTach versus an SVT. With aberrancy, what is called. And what I mean by that is an SVT with a ventricular conduction delay, such as a bundle branch block. So we have these wide complexes due to the bundle branch block, but they still have a sinus rhythm, and then they go into SVT. It can be easy to mistake that for VTach because they have wide complexes and no P waves. But there is some ways to differentiate between SVT with aberrancy and wide complex or with VTach. When in doubt, treat for VTach. It's the most lethal of the two rhythms, and the majority of patients are going to actually be in VTach. It's about 80%. It is important to understand, be able to differentiate between the two of them. It's important because it's going to differentiate the treatment that we provide. It should be fairly easy to differentiate between SVT with aberrancy and VTach in about 90% of cases. So, how do we do it? VTach is very regular, except at the beginning of the rhythm. The irregular ventricular rhythms are polymorphic VTach, torsades, and VFib. Oh, excuse me, guys. Irregularity favors an SVT.
Pre-show available from station number
1. Like I was saying, irregularity favors SVT, as you have uncontrolled AFib, multifocal atrial tachycardia, junctional tach, that can all be irregular. So irregularity is generally going to favor more towards SVT. Looking at multiple leads is another good way to distinguish between the two. Many waves that are isoelectric in certain leads. If you have a positive deflection of AVR, if you have a 12 lead available, and you have a positive deflection of AVR, this is a positive sign for ruling in VTAC. That is an example of that. It's just important to realize that lead 2 is not always the best lead to view an arrhythmia. Long rhythm strips are extremely helpful, and comparison with an old strip, and even the patient's history are going to be good indicators and down a certain path. Patients greater than 65 years of age, more than likely going to be VTAC. Younger than that, it's possible that it could be SVT with aberrancy. The width of the QRS complex is another good indicator. The wider the QRS, the greater the chance that it's VTAC. A couple more notes on that. Excuse me. And I believe that we'll discuss them in a later PowerPoint as well. But there are some other signs, such as we already discussed Josephson's sign. Brugada's sign is another one. Fusion and capture beats, which we should be discussing later on as well, are other good indicators of ruling in VTAC. Okay. Ventricular fibrillation. This is another lethal arrhythmia. It's a rapid, completely disorganized ventricular rhythm. No discernible morphology. The undulations of the waves can occur anywhere from 150 to 500 minutes. You can have fine and coarse VFib. So if you look at the top, it's a lot more finer version. There's a pretty wide spectrum up to the coarse VFib that you see in the bottom. Asystole, excuse me, is the complete absence of electrical cardiac activity. This is the straight line. This is the easiest one to pick out. If you guys have any question, if you have any trouble with EKGs, you should always be able to pick out asystole. The patient is clinically dead at this point. You need to clinically correlate the rhythm to your patient to rule out that a lead fell off. That's why we always consider our check asystole in at least 2 leads. This is a terminal rhythm. An agonal rhythm is basically asystole with an occasional complex thrown in. It's about as close to asystole as you can get without actually being asystole. So, and what we call here, if you see this extremely wide bizarre complex down here in the picture, we call this downward displacement of the pacemaker. As the cellular death continues down to the very last cell, you will get wider and wider complexes that you'll start to see. The reason for this is that you have this. It was basically like the last-ditch effort for the heart cells to try and survive. It's a survival mechanism. They'll get extremely wide as you have this real slow cell-to-cell conduction occurring, and it's really not able to be correlated to any type of heartbeat or heart tone. It's just electrical activity at the point of it being an agonal rhythm. All right. At this point, we're going to talk about AV blocks, AV nodal blocks. It's kind of going back up to the AV node. I know we kind of already went over that, but I wanted to talk about these blocks after we talked about the ventricles and the ventricular rhythms. I think it makes it a little easier. So keep in mind, through these next few rhythms that we talk about, we are discussing blocks that are occurring around the AV node. AV blocks are formed when conduction of the supraventricular impulses are blocked through the AV node or the ventricular portion of the electrical system. So it's either partially or completely blocked from reaching the ventricles. All right, so we have multiple types of AV blocks. We have a first degree AV block, we have a second degree AV block, we have a second degree type 1 and 2 AV block, and then we also have a third degree or complete AV block. You also hear the third degree heart block referred to as AV dissociation, or sometimes it can also be used interchangeably with the term trifascicular block, which is kind of a misnomer. So basically, you have to understand that that these blocks that we're talking about are basically a stepping stone transitional failing process. They occur over time. So you'll see this, generally you'll see a patient that's in one or the other, that they're in the spectrum. They're traveling towards a complete heart block. So this can take place over months or years. But it is a pattern that continues. Most of these patients, once they start having some type of heart block due to MI or congestive heart failure or whatever, are generally going to be lined up for a pacemaker. So our first group of heart blocks are all incomplete. We have the first degree heart block, which is just more of a delay than anything. The first thing we need to remember with a first degree heart block is that we don't drop any beats. In all the second degree heart blocks, we do drop beats. That's the distinguishment between those two. In the third degree heart block, we have a complete heart block, so there's no association between the impulses coming from the atria or the SA node. None of those are reaching the ventricles. So, like I said, when none of the P waves are blocked, it's a first degree AV block. When some of the P waves are blocked, it's a second degree heart block. And when all of the P waves are blocked, it's a third degree or complete heart block. So if you guys remember, on all of our recognition of rhythms, there's these drop beats and group beats, and most of them up to this point have said none. Well, these are the three rhythms, or the two rhythms are the ones where we're going to start to use those to recognize some of those. So whenever we have a first degree AV block, we have a delay in the conduction of the impulse from the SA node to the ventricles. It's a long enough delay that it's going to increase the PR interval longer than 0.2 seconds. So the delay is most commonly in the AV node or the bundle of His, but it can be lower than that or higher than that as well. Conduction to the ventricles is still going to occur every time. We're going to lose any beats. It's just going to be delayed. So, our example here, in the top one, we have our normal PR interval with where the impulse is traveling, and in the bottom we have our example of a first degree AV block. The AV node is partially blocked, causing that stimulus to slow down more than it should in the AV node, and creating a lengthening PR interval. So we can have pretty long PR intervals. Recognize that each QRS still has a P wave. There is a spectrum depending on where the block actually is. And we can have consider the fact that a PR interval of 0.24 is a first degree block. But you can have them as high up to 0.4, 0.5 seconds, which is a pretty significant AV block. This is something that's going to be progressing into a second degree heart block fairly soon, more than likely. So, recognizing a first degree AV block, the only difference in this is, we have a the rate is not necessarily important in distinguishing. Our rhythm's still going to be regular. P wave is going to be present still. Our P to QRS ratio is still 1-to-1. We still have a P wave for every QRS. We have a PR interval longer than 0.2 seconds, and everything else is normal. So basically, our big distinguishing characteristic here is the fact that the PR interval is longer than 0.2 seconds. Okay, so here we have an example of an EKG with a first degree AV block. Looking down, only thing we need to look at here, look down at the very bottom in lead 2. Look at your PR interval, find your P waves. Every QRS has one. We didn't drop any beats, but our PR interval is greater than one big box. So that means we have a first degree AV block. Okay. Second degree AV blocks. These are characterized by both the presence of P waves and intermittently dropped QRS complexes. What that means, we're going to have P waves that don't have a QRS complex attached to them. So grouping is the major characteristic of the block. Usually you're going to have one drop QRS complex per group. And you have two main subtypes of second degree. You have Mobitz 1 and Mobitz 2, or type 1 and type 2. When we use the word conduction, we're referring to the ratio of P waves that conduct to the ventricles. So a 3:2 conduction in a second degree block means that in a grouping, there are 3 P waves and 2 conduct normally to the ventricles and 1 does not. When we use the word block, we're comparing the number of P waves in a group and the number of P waves that have been blocked. So a 3:2 block means that in a grouping, there are 3 P waves and 2 P waves are blocked from reaching the ventricles. So grouping is one of the major diagnostic features of second degree AV blocks.
10-4, the only information we have is a male patient laying on the sidewalk in front of us.
So, look at our top ECG there. We have 2 QRS complexes with P waves attached. And then we have a P wave with no QRS. And then we have 2 with QRS attached. And then we have a P wave with no QRS. So we have 2, and then we drop 1. We have 2, then we drop 1. That's 3:2 conduction. Next one down, we have 3 conducted beats, and then we drop 1. So that's 4:3 conduction. And then the bottom one is variable conduction, because it's just changing intermittently. So for a second degree type 1 heart block, the criteria are a PR interval that is progressively lengthening until a P wave is eventually blocked. So the shortest PR interval is going to be the one that immediately follows the drop beat. The longest PR interval is going to be the one immediately before the drop beat. So here's what we're talking about. We have a short PR interval, which is going to, the one following the drop beat is going to be the shortest, and we have a slightly longer PR interval, even longer, and then we drop a beat. Again, we have the longest PR interval at the closest to the drop beat. So it's going to be the beat just before the drop beat. Here's some examples of second degree type 1 heart block. So if you look at the top in 3:2 conduction, we have a beat with a regular PR interval, and then we have a slightly longer PR interval, and then we drop a beat. And then we have a regular PR interval, slightly longer, and drop a beat. And it continues that way. So we'll have a short PR interval, and then which it gradually lengthens until we drop a beat. The next example down is an example of 4:3 conduction. We have a lengthening PR interval until the 4th beat where we drop 1 and the cycle starts over. And then we have example of variable conduction below. All right, moving on. Talking about second degree type 2 heart blocks. So either a single or non-sequential non-conducted P waves in the face of a rhythm with constant PR intervals. So what we're going to see here, we have constant P-to-P intervals throughout the strip, and in most cases they're going to be greater than 0.2 seconds, but that's not a rule. But we're going to have a constant PR interval. Our PR interval should never change. And we're going to have drop beats in a cyclic fashion. So here, this is the differentiation between type 1 and type 2. We have 3 to 2 conduction. Our PR interval stays the same. We have 2 beats, and then we drop 1, 2 beats, and we drop 1. 4 to 3 conduction, PR interval is the same. We have 3 beats and drop 1, 3 beats and drop 1. And that's pretty much it. In second degree type 2, the QRS complex can be narrow or wide, depending on where the side of the block is. The majority of these blocks are going to occur in the bundle branches, so they're going to have a wide complex. Occasionally, it can happen in the bundle of His, so it can be a narrow complex. This is a dangerous heart block because you are very dangerously close to moving into a complete heart. A complete heart block, or this second degree type 2, is caused by a permanent type of defect, meaning structural abnormality or cell death in the tissue from infarction. All right, you can have a heart block that is untypable. You can have a heart block that is untypable due to the fact that you have 2 to 1 conduction. You're dropping every other beat, so you don't have any opportunity to determine if you have a lengthening PR interval or not. These are just untypable second degree blocks. All right. High grade or advanced second degree heart block. If you have at least 2 consecutively blocked P waves, you can make this diagnosis. This is very sinister finding. These patients are on their way to developing a complete heart block as well. Okay, so recognizing our second degree heart blocks, type 1, we're going to have our variable rate. It should be fairly regular. We're going to usually have a normal upright P wave. Our P to QRS ratio is going to be 1, except when we're dropping a QRS. The P interval is going to be lengthening. It is variable. The QRS width should be normal. And we're going to have grouping of beats, and we are going to have drop beats. In type 2, again, everything is the same. The only thing that's changing is the fact that we also have drop beats here, but our PR interval should be consistent. It could be long, but it should not change from beat to beat. We are still going to have grouping, and we will have drop beats as well. Okay, we're going to talk about third degree heart blocks. What happens when we have a third degree heart block is there's no communication whatsoever between the atria and the ventricles. The atrial and ventricular rates are going to be different. You're not having any capture from supraventricular pacemakers. The key feature is that PR intervals are completely changing and have no effect on the ventricular rate. There's not going to be any discernible relation between P waves and the QRS. So, looking at our 2 examples, on the top we see what would be a high-grade heart block. We have an R to R interval of our QRS complexes. We have a P to P interval of our P waves, and there's no correlation. Again, with the bottom, this would be a lower degree heart block. We have a very bradycardic ventricular escape rhythm with the P waves on top, kind of buried in some of them even. This is another example of a complete heart block. There's no correlation to the P waves or the QRS complexes. So just kind of an overall overview of what our heart blocks. We have a first degree heart block where we're not dropping any beats, and we have a prolonged PR interval greater than 0.2 seconds. Our type 1, second degree type 1 heart blocks have a consistently lengthening PR interval until we drop a beat, and our second degree type 2 heart blocks have a consistent PR interval, and then they're also dropping beats. Our third degree heart blocks are no correlation from our P waves to our QRS complexes. They're completely independent. All right, we're going to talk about briefly artificially paced rhythms. So artificial pacemakers, pretty common. You're going to see these quite often. Basically they have an implanted wire into the depending on what type it is, they can be inserted into the right ventricle, into the apex of the right ventricle. They can have wires in the atrium that are helping the atria have their pump. There's a lot of different types of pacemakers, different makes and models that have all kinds of different features. Best way to tell if somebody has a pacemaker is to just feel, you'll feel a lump just inferior to their clavicle on the left side. This is generally where the pulse generator is inserted surgically. So the pacemaker spike is fairly distinguishable wave on our ECG. They are generally they generally stand out because they don't really have the look of a normal, part of a normal heart rate. They're usually straight up and down. They usually have a very small deflection on an EKG. Pacemaker spikes may not be seen in every lead. The best lead to look for pacemaker spikes is V4 in a 12-lead EKG. What these pacemakers doing, if anybody's not familiar with what happens, if for whatever reason they have trouble, their heart's unable to be the pacemaker, this pacemaker wire goes in there and provides a stimulus. It beats whenever it needs to. They have demand pacemakers that only beat when the heart fails to. They have fixed pacemakers that are beaten all the time. It depends. There's a lot of different types of pacemakers. So they are what start the electrical stimulus. So whenever you do have a pacemaker, you are going to have generally a wide complex associated with that, because it's just like an ectopic focus in the ventricles that's firing. And that creates that wide complex. The pacemaker does the same thing. It's generating that impulse in the ventricles, so it provides the same stimulus that a ventricular impulse would. So QRS morphology in a pace complex, you're going to have the wider than 0.12 seconds, bizarre in appearance, ST wave abnormalities. You cannot make any mention of hypertrophy, access, or infarct in most cases in an artificially paced complex or rhythm. And this will make a little more sense as we go on. It's not entirely accurate. You can still identify infarctions to a certain extent with pacemakers. But hypertrophy and access are going to be thrown off significantly due to that artificial lead. Atrial demand pacemakers, they're used for patients that have bradyarrhythmias, but also still have a functioning AV node. Basically, they sense the atria, and they pace the atria in an inhibitory fashion. So they are basically, patients have a sinus node dysfunction. It's going to be used to assist that sinus node, providing an impulse whenever it's unable to. Everything beyond the sinus node is still functioning, so it doesn't have to have a wire placed in the ventricle. So your QRS complex with these types of pacemakers is going to be what you would expect to see in a normal patient without a pacemaker. Ventricular demand pacemakers, They sense and pace the ventricles in an inhibitory manner. Atrial activity does not affect the ventricular wire. Here you have your example of what your pacemaker spikes look like. AV sequential pacemakers are dual sensing. They have a wire in the atrium and in the ventricle, so they basically provide your full range of conduction through the heart. They stimulate the atrium, then slightly later they stimulate the ventricles. So here you have an example of what that would look like on an EKG. The pacemaker spike with 2, you see the pacemaker spike in front of the P wave, and you see the pacemaker spike in front of the ventricle. Okay, so in conclusion, the most important thing about a paced rhythm is recognizing it. Like I said, V4 on a 12 lead is going to be your best lead to look at, and when looking for a ventricular pacemaker, because this is the lead with the closest to the wire. At this point, everybody go ahead and proceed to the quiz on ventricular rhythms, wherever that's at. And this will be the conclusion of our lecture on ventricular rhythms, heart blocks, bundle branch blocks. Whenever we come back, we're going to start. Basically, guys, this is it. That is rhythm interpretation right there. We've covered the vast majority of rhythms that can occur in the heart. So when we come back, start talking about 12-lead interpretation, and then I believe first we'll get into cardiac emergencies, so we can actually correlate some of these rhythms to and talk about our treatments for them. So go ahead and take that quiz, and we will be back at it shortly.